and good afternoon, all of you. So, today my topic is navigating the challenges of difficult to treat asthma. So, in day-to-day practice, we are encountering a lot of asthma patients with inhalers. So, patients are continuously with inhalers and a lot of medication, but persistent symptoms are there. Then we can how to handle this type of difficult to treat asthma patients. So I directly go to the case history. We encounter one patient, so 52-year-old lady. She's a housewife, presented initial presentation in 2022 in our clinic. So initial presentation is cough, wheezing, and exertional dyspnea. So for the wheezing, that means asthma was diagnosed nearly 20 years. So main trigger factors are dust exposure and cold weather. She took medication herself with inhalers mainly on the time of exertion, but no hospital admission was required. So past 3 months, her symptoms was increased with persistent wheeze and dyspnea increased. The MMRC is great, it's 3 to 4, with on and off sputum production. So on examination wise, there's no feature suggestive of any connective tissue disorders, or her BMI is normal. Other than that, no clinical history of exposure to any allergic or any allergens or no smoking history. So on respiratory examination wise, she had a widespread of bronchi and saturation is 97% on room air. Other than that, other examination, other system is normal. So her medication history on that time in 2022 with the initial presentation, she was on salmeterol fluticasone combination and salbutamol SOS basis. With her inhaler technique was good that time. And she was on prednisolone 10 milligram SOS basis with her own, or sometimes she contacted the GP and she took medication during the exacerbation time. So up to 2021, she took medication nearly 4 months or 4 to 5 months because of this exacerbation. But 2022 to up to presentation to November to our clinic, she almost always took this reliever medication and also prednisolone because of this worsening of symptoms. So during that time, we did a asthma control test, that tool to assess whether is asthma is controlled or not. So this is the online as available. We can calculate. So with that 7 out of 25, this her asthma control is very poor during that time. So I'll stop here. With that, I'll go to the some quick definitions for this asthma. So asthma is one of the heterogeneous disease. So that is according to the GINA 2024 update. They are mainly focus on wheezing, shortness of breath, and chest tightness and cough, and variable expiratory alcohol limitation. This is the asthma definition we all know. So asthma heterogeneity, they are mainly focused on the GINA 2024 guideline. It's mainly these are phenotype based and endotype based and clinical features and treatment responses. So we have to know what is poorly controlled asthma, what is difficult asthma, what is severe asthma. So we have to know this definition. Then only we can move to our case. It will be easy. So what is poorly controlled asthma? Poorly controlled asthma that will assess according to the asthma control test or with the GINA assessment assessment of asthma control with the past 4 weeks of the symptoms. So with the well-controlled asthma, the patient's diagnosed with asthma, patient have fewer symptoms and no nighttime symptoms, no use of SABA or LAVA, or no restriction of physical activities and no abscission of the due to asthma. Then consider the polycontrolled asthma is a patient have some daytime symptoms more than 3 days per week and nighttime symptoms and 3 doses of SABA per week and also restricted physical activities and exacerbation over the previous month. With that, what is difficult asthma? Difficult to treat asthma is uncontrolled asthma despite of medium or high dose of inhaled corticosteroid with second controller, or sometimes patient on the maintenance oral corticosteroid that is require high doses of treatment to maintain the symptoms and reduce the risk of exacerbation. So in this patient, it means it is not a difficult patient actually. So asthma may appear difficult to treat because the modifiable risk factors and also patient don't have some inhaler technique, poor inhaler techniques, and poor adherence and persistent allergic triggers, and sometimes patient on the comorbidities. So we have to treat and consider these things. And what is severe asthma? Severe asthma is one of the subset of difficult to treat asthma. So that is uncontrolled despite of adherence. the maximal and optimal high dose of inhaled corticosteroid and LABA combination, and we should optimize the contributory factors. And also it will worsen when the high dose treatment is decreased. So that is called severe asthma. So we should know how common is this severe asthma. According to the GINA update, there are diagnosed asthma patient. 24% of the people are in a high intensity of the treatment. They are taking high dose of inhaled corticosteroid and LABA medication. With that, 17% out of 24, they are difficult to treat asthma. They are in the high intensity treatment with the poorly controlled symptoms. With that, 3.7% of the categories are severe asthma. They had high intensity treatment with the poor control and good adherence and good inhaler techniques. So according to the ERS-ATS guideline, they in the 2016, they classified in the 5 steps to identify the severe asthma in our clinical setup. So first thing is we should diagnose, confirm the asthma. Second thing is we should address the comorbidities. Third step, we should identify what are the aggravating factors that aggravate the asthma. Fourth step is inhaler techniques and compliance. Fifth, patient is on adequate treatment or not. So if all the 5 steps are completed, patient still symptomatic, we have to consider this patient have a severe asthma. Then we have to go for the specific treatment with the phenotyping and biomarkers. So we come to the outpatient. First, we should confirm the diagnosis. So we did a basic investigation for this outpatient. So full blood count done. Only the positive finding is eosinophil count is 8%. Chest X-ray is a high beam inflated chest, and ESR, CRP, everything is normal. With the sputum culture, everything is normal. Then we did a spirometry. So spirometry done. There's a obstructive pattern is there with the post bronchodilatory effect is there. But patient difficult to perform because of these exacerbations and control. And we did a HRCT test to exclude other associated comorbidities with the COPD or any bronchiectasis or any ABPA. So the lung field side everything is normal. So with patient difficult to perform these maneuvers, lung maneuvers, mainly in the lung function, traditional lung function test. So in this patient, we go for the impulse oscillometry. So impulse oscillometry, that's giving the ultrasound wave to the lungs that identify whether it is resistant to lower small airways, large airways, medium airways, as well as the elasticity. So in this patient have a small airway disease resistant, 5 Hz resistance is there, and no elasticity, so COPD, and also that other pathology excluded. So this patient have a small airway disease. Then we have to remember, so what are the asthma mimics and differential diagnosis for this patient? So most common differential diagnosis are vocal cord dysfunction and laryngeal spasm, and dysfunctional breathing, bronchiectasis or ABPA, and eosinophilic syndrome like chest strokes, and fungal sensitization, excessive dynamic airway collapse, and endobronchial lesion, and obesity-related asthma, and some drugs. So with that, in outpatient, we did ANCA studies because the eosinophil count is high. Sometimes maybe ANCA-related vasculitis also can present with this type of asthma. So ANCA study is negative. ENT referral was done, then vocal cord is normal, and sinus and no polyps. Cardiac are done to exclude this patient have excessive dyspnea. Sometimes cardiac failure also associated. Sometimes the pulmonary hypertension also be associated. That also excluded. So bronchoscopy was done to exclude excessive dynamic airway collapse and any endobronchial lesion. So that also excluded. So according to this diagram, so first part is completed. So we confirm the diagnosis that is asthma. So second thing is we should address if patient have any comorbidities during this asthma. So according to the European Respiratory Journal, they give the what are the influence of comorbidities on the asthma. So then outpatient we did ENT referral done to exclude any allergic or polyps or any chronic sinusitis. That was not there, and GORD features are not there, and patient is not obese, and OSA features are not there, and ABP atopic dermatitis are not there, and patient don't have a smoking or COPD is not there. So patient hyperventilation and glottic dysfunction, and sometimes patient have a psychological dysfunction also sometimes we consider. So with that we have to exclude the safety. So we did a cardiopulmonary exercise test to exclude some dysfunctional breathing to the patient. So this dysfunctional cardiopulmonary exercise test suggests you obstructive airway disease, but there is no dysfunctional breathing. So second step is completed. So with that third step, we have to go for what are the aggravating factors for this asthma. So common aggravating factors are mentioned in the guidelines. Main thing is ongoing allergic exposure and triggers. Sometimes in patient exposed to some allergens continuously, so that will aggravate the. And also sometimes the patient presented with asthma and COPD overlap, or sometimes ABPA, that also may aggravating factors. So in our patient, we excluded those things. Then fourth and important thing is we should address the technique and compliance. So the top three errors reported in inhaler techniques according to the Chest Journal in 2016. Main coordination and inspiration and breath hold. These are the main top three errors. They are reported in the inhaler techniques. So each and every visit we should check and recheck for this inhaler technique, and dedicated staff should be allocated for this inhaler technique. So we should on our patient we checked, and each and every visit we checked and rechecked with the inhaler techniques. Then another important thing is here we see the 4 steps are completed. Another important thing is adequate treatment. Is this patient the adequate treatment? So it's another question. So according to the GINA 2024 guideline, there are 2 steps, 2 trackers there to the up to step 5. So with that, we can use the MARC therapy, the inhaled corticosteroid with the formoterol combination as a reliever and also as a controller. And also we can add on if the symptom persists, we can add the LAMA, LABA, or sometimes azithromycin according to the symptom. With 2022 outpatient, once we present, we address the patient to advise the physical activity, and ask the patient to arrange the chest physiotherapy, and also we check the inhaler techniques, and we added the NHSL metropropticosone combination and the salbutamol basic with theophylline, and we started the tapering regime of prednisolone, and patient vaccinated with pneumococcal influenza and COVID as well. Then after presented to clinic to 2022 to 2024 meet, she developed, she had a 5 hospital admission with acute exacerbation of asthma that treated with IV antibiotics and steroid with no ICU admissions. And also at that time, we optimized the treatment after that with the current medication, patient on budesonide and formoterol combination, and we added thiotropium to control symptoms, and also the salbutamol SOS basis and thiophylline, citracin, and montelukast, and patient maintain an oral prednisolone regime with her usual antihypertensive, but she need a regular reliever medication, and also she has some persistent symptoms that activity of daily living it affected because of these symptoms. So here we all the steps are checked, and complaints and comorbidities and technique are addressed. So patient still symptomatic. So what are going to do next? So according to this diagnostic step, we completed these 5 steps. So another important thing is we should go for the specific markers. We identify the phenotyping and biomarkers for this specific therapy for this patient under category of severe asthma. So the final step is we can identify what is phenotyping of severe asthma. The phenotype is improved characterization of the disease could contribute to the improved selection of appropriate treatment. So in the phenotype, the set of observable characteristics of individual resulting from the interaction of its genotype with the environment. So sometimes patient have atopic asthma or obesity. So its endotype is called subtype of this condition, which is defined by the distant functional or pathophysiological mechanism. So it's eosinophilic asthma, sometimes called T2 high asthma, sometimes called T2 low asthma. So according to the GINA 2024 update, there are this is a very most common clinical phenotypes. They mentioned the allergic asthma, late onset of asthma, and non-allergic asthma, asthma with fixed airway obstruction, asthma with obesity, and cough variant asthma. These are the very common asthma clinical phenotypes. So with these clinical phenotypes, we have to identify what are the endotypes. So with the endotypes, that is dependent on the airway inflammation. So this airway inflammation, we can identify some investigation by this airway inflammation and type 2 mediated airway inflammation. That is, we can do the serum IgE levels, the sputum or blood eosinophil levels, and FeNO or serum periostin. So in our patient, we did additional investigation to identify which category is our patient. So we did a total IgE levels. So total IgE is high, And we did allergic specific IG levels for Aspergillus, Candida, and cockroach. Because these IG levels we did check because of these patients. Sometimes these can specific allergic levels are there. That also one of the triggers. So we should remove that one before to treat these biologics and those things. So that's why we did a total IG specific, allergic specific IG levels. And also pheno. We did a pheno here 14, 15, and 12. Because this here the pheno is more than 25 is considered as a eosinophilic inflammation of the airway. Here is pheno is less than 25. That's normal because this patient is on the inhaled corticosteroid and oral corticosteroid. Because when we do the pheno, we should omit that inhaled corticosteroid nearly 3 to 4 days. After that only we can proceed this pheno. But in our patient, we difficult to stop these inhalers. That's why these pheno levels are mainly low. And the blood count, full blood count is eosinophil count is 3. So according to, we come to the pheno, there's a few words about the pheno. So pheno we can mainly adjust for, mainly check for the eosinophilic inflammations. So if the pheno is more than 25, it's considered as a eosinophilic inflammation. It's suggested, then if it's there, we can go for the corticosteroid treatment. If it is adequate treatment is there, we can continue. So if it is a normal or low pheno or normal sputum eosinophil count is there, we can identify, treat any aggravating factors. So we can treat the other other treatment options we should consider. Or if it's inadequate response with the corticosteroid, we can go for the inadequate response. We can identify whether it is normal or if we can go for the anesthetic. If it is a inadequate response, maybe due to treatment taking treatments correctly, we can address the compliance and the increase the dose of needed specialty referral. So this is very important slide. We should know the pathophysiological mechanism to identify the enterotypes of the asthma. So the asthma broadly classified the eosinophilic asthma and non-eosinophilic asthma. So that means type 2 asthma and T2 low asthma. In the type 2 asthma, allergic eosinophilic asthma, the mediators are mainly IgE and IgE and interleukin 4 and interleukin 5 and TSPL. So, and also non-eosinophilic are mainly granulocytic and neutrophilic inflammation. There's an IL 33. So, with targeted treatment for these interleukins, that will help to prevent the asthma exacerbation in future. So in severe asthma, targeted treatment biomarkers they broadly classified. Mainly in one hand is the Ig high, and another thing is sputum and blood eosinophil is high and low. So here the sputum Ig total Ig high and with blood eosinophil is high. That is atopic asthma with eosinophilia, and the sputum blood eosinophil is low with the total Ig level is high. That is called atopic asthma. Both are low. That is considered as a type 2 low asthma. The treatment options are mainly macrolides and broncho thermoplastic. So these are some approved biologics in severe asthma. We all are know infliximab, nemolizumab, and depemokimab, and tocilizumab. There are no head-to-head trials available for these biologics. So when we come to the outpatient, we optimize the treatment with budesonide and formoterol combination with maximum dose of tiotropium and salbutamol, cetirizine tablet. And also we had the maintenance dose of azithromycin for this patient. If the patient have a good compliance but no comorbidities. So we did the lung function test, but there's a reversibility is there. And but when we assess this asthma control test and also with the GINA assessment of asthma, so patients still use the reverse for more than 2 times per week, and daytime symptoms is there, and one exacerbation that lead to hospitalization. So according to that score, that was 11. So but still, in the patient is less than 50, the patient still have a fully controlled asthma. So what is the next option to our patient? So here is patient is asthma is still not fully controlled. So we can go for the according to the GINA guideline. Again, we come to the beginning. So we assess the patient, our diagnosis is correct or not, and patient identify if the patient have any comorbidities, address the patient is on any patient on any techniques, inhaler techniques are correct or not. So these things are addressed. So our patient completely well. Then we can go to the multidisciplinary approach is needed for this further management. These are some proposed multidisciplinary approach guideline in the 2016 severe asthma guideline. We should accurately diagnose the phenotypes and optimize the treatment plans, enhance the patient education and self-management, and comprehensive monitoring and follow-up and management of comorbidities and conduction care and personalized care. And also we should maintain the severe asthma registry. So these are some examples of these multidisciplinary uh, formats that were maintained in the tertiary center at the UK. So when we come to the outpatient, so outpatient is in the severe asthma category. So phenotype is adult onset asthma or late onset asthma. So with the patient have a type 2 asthma because this patient have a high IG levels and blood eosinophil size are there and phenols are normal and patient have a exacerbation for more than 4 past years. So according to that, the patient under category of atopic asthma with eosinophilia. So what is the next option? This patient actually is benefited for biologics. So according to the GINA 2024 update, there are some selection criteria for these biologics. So the total IG level, anti-IG omalizumab, then the patient have a phenos more than 25 or high IG levels, and the patient having atopic. So there's a no, there is a no IG omalizumab, we can go choose for that another and the anti-IL-5 because there's no hard and fast rule for the which antibodies to select this patient. So in our patient, we can identify there's a peripheral blood eosinophil count is high with a history of exacerbation. And patient have adult onset of asthma. So it's most benefited from this mepolizumab or pembrolizumab. Unfortunately, in Sri Lanka, we don't have these antibodies. So when we started these antibodies, so what are you going to do? So we check these patients for every 3 to 6 months. If it's a good response is there, we can taper the oral corticosteroid and stuff and decrease the inhaled hours corticosteroid, but we don't stop this inhaled corticosteroid. And we stop the LAMA and other modifiers. If the good progression is there, we should consider this biologic for 12 months and assess the progression. If there is a poor response to the biologic treatment, or unfortunately we don't have the biologic. So in our setup, what are you going to do? So involve again the MDT meeting with the primary care physician and respiratory specialist. We every 3 to 4, 6 months we should assess the patient. With that comorbidities we should address and treat the patient, and we should address the patient concern, and we don't stop the inhaled corticosteroid, and also we address any other issues to the patient. So, and the important thing is we have to move on. So we have to focus on the advanced treatment for severe asthma rather than common inhalers and corticosteroid therapy, because there are other centers in other countries. There are a lot of antibodies they are using for nearly more than 20 years. Still, we don't have in Sri Lanka. So why we have to move? Because in global asthma report in 2022, they consider as they told in Sri Lanka. So asthma-related death, they contributed to nearly 5% of the total death in the country. Because when we had patient admitted with the acute exacerbation of asthma, the cost is more high than this simple omalizumab and those antibodies. So my final conclusion is difficult to treat severe asthma needs systemic evaluation steps. We have to check and recheck adherence and compliance and optimize the treatment. Always look for the asthma comorbidities and asthma mimics. And asthma treatment almost always individual-based approach. And MDT is essential for this severe management of asthma. So I would like to thank Dr. Amita is my trainer, and Dr. Abdul also, and also Dr. Sudesh and Madhubani Chaudhary and Pravina and Dr. Namath.